So we all know the trabeculectomy remains the most commonly performed surgical intervention for glaucoma, but the use of glaucoma drainage device is on the rise, especially for the patients with a secondary glaucoma or high-risk patient. The Ahmed valve glaucoma, just like Dr. We said, it's commonly used, and it's with a unidirection valve. It has a better safety profile compared to other type of glaucoma drainage system. However, there's two, I think, is the main drawbacks with the Ahmed valve plate. One is the high rate of hypertension phase. The other is a limited long-term outcome, which I want to share with you our experience and how to overcome those two problems. So hypertensive phase, we know if you down the Ahmed valve, it may happen up to 50% of patients, pediatric patients. So their study shows how to avoid this. One is to use early use aqueous suppression medications, such as timolol or dorzolamide, or combination of this, or brimonidine. So there's two studies on this, and both of them shows early use of aqueous suppression when the pressure greater than 10 millimercury during the early post-op period can significantly decrease hypertensive phase. So even so, we think in the Iran paper, the hypertensive phase still has been reported about 25%. And another problems we want to improve with Ahmed valve is the long-term outcome. So we all heard about the ABC study, which is a national study to talk about the 5 years treatment outcome, compare Ahmed versus Barwell. This is their definition of the failure, and then the report about 5 years, the failure rate could be about 44.7%. So how can we, the question we're asking is how can we maintain the safety feature of the Ahmed valve, which we really all like it, but also overcome the drawbacks? So we thought about our old friends of mitomycin, because nowadays nearly everybody uses mitomycin in the trabeculectomy. So how about with Ahmed valve? There's at least 2 papers published discuss intraoperative use mitomycin alone, and then the result is not promising. That means if we only use intraoperative mitomycin alone, it does not increase short or intermediate term success rate of Ahmed valve implantation. So then most of the patients give up at this point. They say it doesn't help. However, if you look more closely about their study, you can say the study did show a significantly reduction in the pressure at 7 days, which is 1 week, and then 2 weeks of a post-op period time. So we're thinking, is that maybe only intraoperatively use mitomycin alone is not enough? Maybe we need to use more than that. So why is that? And we're thinking different from trabeculectomy. We actually place a plate on the surface of the eyeball, and then the Ahmed valve plate may serve as a constant stimulus as a foreign body, which may overcome the antifibrotic effect from a single intraoperative mitomycin use. That means not only intraoperative use mitomycin, we may consider is a possible post-op application of a mitomycin may improve long-term surgical outcome. So we're talking about a combination of intraoperative and post-op mitomycin use. So this kind of research has been ongoing at UCSF for more than almost 20 years. It started with Dr. Alvarado. This paper was published in 1990s, and he started with using intraoperative mitomycin and adjunctive post-op 5-fluorouracil with Ahmed valve, and then with 7 years of follow-up. This is his definition of a failure in the study, which is quite similar as ABC study or any other national large-scale studies. And then the promising result is by 5 years. In his study, he reported a cumulative success rate. If it's almond valve alone, it's about 72%. If you combine it with, if you combine it with the phaco, it's about 72%. If 84%, if you almond valve alone, is 72%. So it's significantly better than the 55% reported at ABC study. So every time when we use anti-fibrotic agent, we worry about tube erosion, complications, infections. So within their 5 years follow-up, and then they found that the tube exposure rate is about 1.5%, which is quite within the range of other large-scale national studies. So then in Dr. Alvarado's study, they used a post-op 5-FU injection. During that study, they have 5 post-op 5-FU injections. That means the required patient come in weekly for 5 weeks in a row. We think that's maybe too much for the patient, especially in the area we don't have good follow-ups. So then we asked the question, can we decrease the number of post-op injection by introducing mitomycin instead of just 5-FU alone? So we did a small study here. It's all resident-performed almond valve glaucoma at the San Francisco VA hospital. It's a retrospective study about 41 patients. So for all the patients, we have an interruptive mitomycin use. We also have a post-op combination of 5-FU and the mitomycin. And we found out with mitomycin group injection, with definition of a success about 21%, we have success rate of 86% by 1 year versus 58% without injection. And then the complication rate are comparable between both groups. We know it's a short study, but at least the result is promising. So I just show you like 3 examples in my clinic. This patient is 80 years old, the status post-cornea transplant. He received the interruptive and the post-op mitomycin injection 2 years ago. And then in the right eye, baseline pressure is 8, and without the medication. This is a young boy, 14 years old, that has uveitic glaucoma. He also received the intra and the post-operative mitomycin. Vision's baseline pressure 14 with use of Postop dorzolamide timolol. This is a 60 years old, the primary open-angle glaucoma in the right eye. Baseline pressure, this is 2 years after surgery, pressure is 8 without medications. So for myself, I feel like over 200 patients over past 5 years. Is only 2 patients has a tube erosion, 2 patients has endophthalmitis, but 1 has bilateral bacterial conjunctivitis at the skilled nursing facility. The second patient has immune suppression condition. So here, this is our current regimen I want to share with you. We use interruptive mitomycin injection, 0.4 milligram ml for 0.1 ml. I will show you a video quickly how we're doing this. And the post-op injection for mitomycin is at 1 week and 1 month, same concentration, and also for 0.1 ml. We don't do the injection if the pressure is very low, or if a patient has choroidal detachment, or if there's a shallow chambers or chamber reactions. We think the timing of the injection is critical because we want to, the injection occurs before the dense capsule formed. We always say the mitomycin is not to dissolve the scar tissue, it's to prevent the scar tissue. So here's the small video. So you can do the mitomycin injection either at the beginning of the surgery or after the surgery. So here's what we did is that by the end of the surgery, we closed everything. We did the mitomycin injection over the plate by the end of the case, right here. And afterwards, we just rinse the eye very well. Sometimes, depending on if it's a topical case or block case. If it's a topical case, it will be ideal to give a patient an anesthetic injection first. Here's the quick video about the post-op mitomycin injection in the clinic. So remember, we do it at 1 week and 1 month afterwards. So this is a gentleman. Firstly, we give proparacaine eye drops, so numb the eye. and then we apply with Q-tip of a 4% lidocaine. We really, really want to numb the area very well. You can tell this is African American. Even at 1 week, there is the conjunctiva is very injected, and that means the scar tissue try to form around this area. So we don't want that happen. So we actually use Q-tip 4 times with the 4% lidocaine. Really want to numb this area. And afterwards, we inject the subconjunctiva 2% or 1% of lidocaine over the plate. So the key is the injection site is over the plate, not at the limbus, because you want to prevent the scar around the plate. So here's the lidocaine, either 1 or 2% subconjunctiva. So you make a blister here, elevated the conjunctiva. So this way, patient will be numbed very well. Afterwards, then we do the mitomycin injection. Here we are, injected into the blister we created with the lidocaine. And afterwards, we rinse the eye very well, so then patient will not feel irritated. Just want to repeat the key points of injection. It should be over the plate. That's number 1. Number 2, we need to numb the area very well because mitomycin injection is painful during the clinic. Number 3, we need to rinse the eye very well, otherwise patient may feel irritation. I want to remind everyone just be cautious of a mitomycin application when we deal with the patients with uveitis or has immune suppressions because we worry about the infection and hypotony. So then finally, like last 2 slides, is there any role of a mitomycin with tube shunt surgery? We think that all our retrospective data definitely support it. We're currently doing a randomized clinical trial, and we try to compare if mitomycin can help us control the hypertensive phase and what's the long-term outcome of this. So those are all the centers currently recruiting the patient, and hopefully we can have some result presented to everyone in the future. Thank you.